Isolate embryonic myocardial cells in a petri dish, and they will pulse rhythmically on their own. The human heart generates its own electrical potential at a fixed rate. It requires no input from the brain to initiate a contraction. Look closely at the cellular makeup of the myocardium. 99% of these cells are contractile, tasked entirely with the mechanical labor of pumping blood. The remaining 1% are specialized conducting cells. These conducting cells form a highly specialized electrical wiring network distributed throughout the heart muscle. They function similarly to neurons, initiating and propagating the action potentials that dictate the pace for the entire organ. We need to examine how these two distinct cellular action potentials coordinate the precise timing of mechanical systole and diastole. Mastering this electromechanical duality provides the physiological framework required to understand hemodynamics and interpret clinical monitoring in midwifery practice. The normal sinus rhythm begins in the superior posterior wall of the right atrium. Here, a specialized cluster of conducting cells, called the Sinoatrial or SA node, acts as the primary pacemaker for the heart. The defining characteristic of the SA node's electrophysiology is its complete lack of a stable resting membrane potential at all times. This graph tracks the action potential of the SA node over time. Starting from a low of -60 millivolts, the membrane potential slowly and continuously drifts upward. This drift is the pre-potential or spontaneous depolarization. This steady climb occurs because specialized channels remain open, allowing a slow, constant influx of positively charged sodium ions into the cell. Once the internal voltage reaches the threshold of -40 millivolts, calcium ion channels open. A rapid influx of calcium drives the spike in depolarization, pushing the membrane potential up to +15 millivolts. At peak voltage, the calcium channels close and potassium channels open. Positively charged potassium ions exit the cell, causing the voltage to drop during repolarization. The moment the membrane potential hits -60 millivolts, the potassium channels close, sodium channels reopen, and the cycle immediately restarts. This relentless ion-driven loop is the molecular mechanism of autorhythmicity. It sets the baseline tempo for the entire cardiovascular system. From the SA node, the wave of depolarization sweeps across the superior portions of both atria. This electrical wave triggers the atrial muscles to contract. Atrial systole increases pressure within the chambers, pumping the blood downward through the open atrioventricular valves and into the ventricles. By the time this contraction begins, the lower ventricles are already 70 to 80% full from passive blood flow. The active contraction of the atria, known as the atrial kick, supplies the remaining 20 to 30% of the ventricular and diastolic volume. The electrical wave cannot travel directly down into the ventricular walls. The connective tissue of the cardiac one electrical gateway through this barrier, the atrioventricular or AV node, positioned in the inferior portion of the right atrium. As the signal enters the AV node, it slows down significantly. The nodal cells have small diameters and less efficient conduction properties, resulting in a crucial delay of approximately 100 milliseconds. This 100 millisecond pause ensures the atria complete their contraction and fully empty their blood payload before ventricular systole can begin. After clearing the AV node, the impulse travels rapidly down through the bundle of His and splits into the bundle branches and descends to the apex of the heart, where it connects with the Purkinje fibers. The Purkinje network distributes the electrical signal to the ventricular contractile cells. Because the stimulus arrives at the apex first, ventricular contraction begins at the bottom and squeezes blood upward toward the major arteries. This graph shows the action potential of a ventricular contractile cell. Unlike the SA node, these cells maintain a highly stable resting phase at -90 millivolts and will only fire when stimulated by an arriving impulse. When the stimulus arrives, voltage-gated sodium channels open rapidly. A massive influx of sodium ions violently spikes the membrane potential to +30 millivolts. Then the cell enters the plateau phase. Slow calcium channels open, allowing calcium to enter while potassium slowly exits. This precise balance of ion movement holds the voltage positive for roughly 175 milliseconds. This elongated plateau creates an absolute refractory period of approximately 200 milliseconds. During this window, the cell cannot be stimulated to fire a second time, no matter how strong the incoming signal. Finally, during repolarization, the calcium channels close and potassium rapidly exits the cell, dropping the membrane potential back to the negative 90 millivolt resting state. The prolonged calcium plateau prevents continuous involuntary contraction, known as tetany. It forces the ventricular muscle to relax during diastole, so the chambers can refill with blood for the next cycle. In clinical practice, we measure these microscopic cellular ion exchanges across the myocardium using surface electrodes. This diagram correlates a standard electrocardiogram tracing to the mechanical cardiac cycle. The electrical output directly reflects the underlying cellular events. The P wave represents the firing of the SA node and the resulting wave of depolarization spreading across the atria. The flat PR interval represents the 100 millisecond delay as the impulse navigates the AV node. The large QRS complex records rapid ventricular depolarization via Purkinje fibers, masking atrial repolarization. The T wave represents ventricular repolarization, driven by potassium efflux, marking the beginning of diastole. Connecting specific cellular ion channels to their corresponding waves on an ECG provides the exact diagnostic framework required to interpret fetal and maternal arrhythmias in the clinic. The heart is entirely autorhythmic, but its baseline rate is tightly modulated by the paired cardiovascular centers located in the medulla oblongata of the brain. Left unregulated, the SA node fires at roughly 100 beats per minute. To maintain a normal resting heart rate, the parasympathetic nervous system applies continuous vagal stimulation, a state known as autonomic tone. The vagus nerve releases the neurotransmitter acetylcholine at the neuromuscular junction. Acetylcholine opens potassium ion channels, which slows the rate of spontaneous depolarization and extends the time between beats. When cardiac output needs to increase, the sympathetic cardioaccelerator nerves spring into action, releasing the neurotransmitter norepinephrine directly onto the nodal cells. Simultaneously, the endocrine system engages, with the adrenal medulla secreting epinephrine directly into the bloodstream. These catecholamines bind to receptors that open additional sodium and calcium channels. This sudden influx of positive ions accelerates the SA node's prepotential, inducing tachycardia, while also increasing the mechanical force of ventricular contraction. The complex interplay between the intrinsic pacemaker cells, the protective contractile plateau, and continuous autonomic modulation ultimately dictates the heart's cardiac output. Grasping these mechanisms provides the physiological logic necessary for advanced hemodynamic monitoring in midwifery.